Joining us, guys. Today I'll be talking about metabolic syndrome. I do apologize in advance. I am a little bit under the weather, but I'm not going to let that affect the presentation. If it wants to. Okay, there we go. Okay, so the objectives. We'll talk about the features, prevalence, and epidemiology for metabolic syndrome, discuss risk factors for developing MS or metabolic syndrome, the IDF criteria, IDF being the International Diabetes Foundation, the pathogenesis and the associated conditions. Then we'll talk about drug-induced metabolic syndrome, and this is exactly where integrated care plays an important part. A lot of times I do have the Portage Path staff send patients to me for lab work before being started on medication to make sure that, it doesn't increase the risk of them developing metabolic syndrome as a result of the medications that they're going to be on. We'll talk about the diagnosis and the treatment, which includes lifestyle modification, diet, glycemic and lipid control, as well as CBT. Okay, so metabolic syndrome. So before I get into this, it actually started off as a concept in the 1920s that saw that there was a link between high blood pressure, high glucose levels, as well as gout. And then in the late 1940s, that's when they started incorporating visceral obesity, or just that central obesity that we're going to talk about. So according to the IDF, or the International Diabetes Federation, metabolic syndrome consists of abdominal obesity plus two other components, such as elevated blood pressure, low HDL, elevated triglycerides, or impaired fasting glucose. Now, throughout the presentation, you're going to see HDL, LDL, and triglycerides. So just a quick basic overview. So when we get a lipid panel, it'll give us the total cholesterol level. It'll give us the HDL. Now, the HDL is your good cholesterol. So anything beyond 40 is considered good. Then we have the LDL, which is our bad cholesterol. You'll see later in the presentation, it's recommended that we keep it below 100. A few years back, they actually changed the guidelines. Otherwise, it was up to 130 was acceptable. But if you have diabetes or any other risk factors, keeping it under 100 is the widely used reference range now. And then we have the triglycerides, which technically it's not considered bad cholesterol, but the higher it is, the worse your symptom, or more complications that can arise. So we tend to want to keep the triglycerides below 150. And now looking at the widely accepted definition of metabolic syndrome, it's a cluster of metabolic abnormalities implying an increased risk of heart disease and diabetes mellitus. And this bottom quote is from the CDC website. Among US adults aged 18 years or older, the prevalence of metabolic syndrome rose by more than 35% from 1988 to 1994 to 2007 and 2012, increasing from 25.3% to 34.2%, which goes to show that, with the obesity rate as high as it is, metabolic syndrome prevalence is going up also. So, alternative names for metabolic syndrome. We have syndrome X, insulin resistance syndrome, the deadly quartet, or Revin syndrome. So some features. Obviously, the big one is central obesity. And this, you can easily see how to measure the circumference of the waist. There's a slide later on that will go into detail about that also. Hypertriglyceridemia. Low HDL, which stands for high density lipoprotein. So HDL we know is our good cholesterol. So if it's less than a certain level, that's attributes to heart disease. Hyperglycemia and hypertension. So risk factors. The main one is the central obesity or being overweight, having a sedentary lifestyle, which is a strong predictor of cardiovascular disease events and associated mortality. Sedentary lifestyles also associated with central obesity, high triglycerides, low HDL, high blood pressure, and glucose intolerance. Age, So prevalence does increase with age. Obviously, diabetes mellitus, approximately 75% of type 2 diabetes mellitus or impaired glucose tolerance have metabolic syndrome. Coronary artery disease, aka heart disease, so 50% of heart disease patients have metabolic syndrome, and about 1/3 of those patients have premature heart disease. Lipodystrophy, both genetic or acquired, have severe insulin resistance, and smoking. I'm gonna go right into drug-induced metabolic syndrome since it does play an important part in practice, and often, what makes integrated care so valuable is something like this. So medications are also strongly linked with increased predisposition to metabolic syndrome. Some, let's say, if they're going to promote weight gain or, improve appetite, which will possibly cause weight gain, this will alter their glucose and lipid metabolism, so that can also attribute to metabolic syndrome. Depending on the receptor that the medication's acting on, it will alter the normal physiology of the brain. Some will increase appetite, carbohydrate cravings, sedation, and cause decreased motor activity. There might be an altered adipose, which is fat tissue metabolism, fat composition and distribution. A lot of the SSRIs, SNRIs, mental health medications act on neurotransmitters in the brain. 5-HT, that's serotonin, H1 histamine, DA being dopamine, and alpha-1 blockers. Increase in leptin and prolactin levels. These are hormones that, either control weight or, strongly affect how glucose and free fatty acids are metabolized in the body. So by altering that, it does attribute to possibly causing metabolic syndrome. It's a list of medications that may increase the risk, which is a lot of medications that we tend to prescribe in this day and age. Antihypertensives, beta blockers, diuretics, steroids, danazol, growth hormone, oral contraceptives, the thiazolidine diones. It's typically for diabetes, but one of the side effects is increased fluid retention, so the risk of congestive heart failure does rise also. And then psychiatric agents such as antipsychotics, antidepressants, anti-seizure medications, immunosuppressants, niacin, which is interesting because it helps treat low HDL levels, but that itself can cause metabolic syndrome, protease inhibitors, and retinoids. Now, weight gain associated with antidepressants as well as mood stabilizers. So this is just a little breakdown. As with the antidepressants, the common ones that do result in weight gain, we have the tricyclic antidepressants, such as amitriptyline, doxepin, and imipramine, as well as Remeron or mirtazapine. Often also TCAs like desipramine, nortriptyline, SSRIs like Paxil, as well as MAO inhibitors such as phenelzine. The others are occasional or rare. With mood stabilizers, commonly we do see it with valproate, as well as lithium, occasionally with carbamazepine or tegretol, and rare with Lamictal, Topamax, which is used for seizures, as well as some bipolar disorders. Does have one of those effects of possibly causing weight loss or helping assist with weight loss. So, like off-label use. And then just going a little bit more specific into the antipsychotics and their risk of metabolic syndrome or causing metabolic syndrome. Okay, so the clinical factors. Usually they're asymptomatic. The patient's not really going to be complaining of anything. A high index of suspicion is needed for the diagnosis. Usually you can kind of see what they like to call an apple-shaped body or apple, form. In the examination, you would notice an increased waist circumference, increased blood pressure, lipoatrophy, which are pretty much localized areas where there's little to no fat tissue based on the deposition being changed of the underlying fat. And then acanthosis nigricans, or skin tags, which I'll show you pictures of. Acanthosis nigricans, highly linked with possibly diabetes or certain types of cancers. So yeah, this is acanthosis nigricans. This should provide a strong suspicion of index of suspicion that patient may possibly have metabolic syndrome. Okay, so other associated conditions, cardiovascular disease. Obviously, there's an increased risk for new onset cardiovascular disease, ischemic stroke, as well as peripheral vascular disease. Type 2 diabetes, there's an increased risk by 3 to 5 times. These abbreviations you see, that stands for non-alcoholic fatty liver disease and or non-alcoholic steatotic hepatitis. Basically, you'll have a rise in your liver enzymes, but if you're not non-alcoholic, somehow your liver is getting affected. And in those cases, we let the patients know, make sure diet, exercise, make sure anything that contributes to possibly being predisposed to diabetes or may cause heart disease, keep mindful of the ways to make lifestyle modifications so as to not affecting the liver. Hyperuricemia, and that's what we see in gout. PCOS, polycystic ovarian syndrome. Metabolic syndrome is seen in about 40 to 50% of those patients. And obstructive sleep apnea, which is commonly associated with obesity, hypertension, and insulin resistance. As a side note, CPAP is the most common treatment for obstructive sleep apnea, and it doesn't improve insulin sensitivity also. Okay, so the pathogenesis of metabolic syndrome, there's insulin resistance, increased waist circumference, dyslipidemia, or altered cholesterol breakdown, glucose intolerance, hypertension, and decreased adiponectin levels. And this will go into pretty soon also, but you see in the diagram, the waist size, try to stay below 80 centimeters for women or 90 centimeters for men. Anything beyond that will be positive for meeting the criteria for metabolic syndrome. So central obesity is the keystone for pathogenesis of metabolic syndrome. Central obesity itself leads to insulin resistance, and various factors that we see over here play a role in the pathogenesis. And these are all part of our immune system. We see the interleukins 1, 6, and 18, resistin, TNF-alpha, and CRP, which is C-reactive protein. A lot of times if C-reactive protein is inflamed, it's a marker of inflammation. Adiponectin, which we mentioned on the last slide, it's an anti-inflammatory cytokine, which is reduced in metabolic syndrome. So the metabolism or breakdown of glucose as well as free fatty acids are affected by the reduction in adiponectin. And then you can see in the diagram that apple shape that we mentioned a little while ago. So the IDF criteria for diagnosis, waist circumference greater than 90 centimeters in males and 80 centimeters in females. Now, depending on the source and the organization that's providing the information, the standard typically is this. And I think I did included in one of the later slides, there's some leniency in the waist circumference, but as a standard, let's keep it to 90 and 80. So you got the waist circumference plus 2 or more of the following. So hypertriglyceridemia, meaning their triglycerides are greater than or equal to 150. Or if they're on specific medication that may result in triglycerides being elevated. Low HDL levels, so if less than 40 for males and less than 50 for females, or if they're on specific medication. Hypertension, blood pressure greater than or equal to 130/85, or on specific medication. And fasting plasma glucose levels greater than or equal to 100 milligrams per deciliter, or a previous diagnosis of type 2 diabetes. Yep, this just kind of goes into what we just mentioned. And these are also, I guess, they change by the group also. I mean, in the US, this is typically what it is. In Europe, there's a different, set of criteria. Not too different, but numbers are off a little bit, but I included this one. And then, for example, this one, we see that the 102 centimeters for men and 88 for women. So slight difference, but overall, everything else pretty much remains the same in terms of the criteria needed to diagnose metabolic syndrome. Now, the proper way to measure abdominal circumference, locate your upper hip bone and top of the right iliac crest. Place the measuring tape in a horizontal plane around the abdomen at the iliac crest. Tape should be parallel to the floor, and then record measurement at the end of a normal expiration, meaning we cannot suck in our gut. We have to kind of breathe all the way out, and that is what truly is the waist circumference. Now, to make the diagnosis, obviously, if anything's following the IDF criteria, that would make the diagnosis. We have to rule out history of symptoms of obstructive sleep apnea in all our patients. And same with history of polycystic ovarian syndrome in premenopausal women. There's a family history of cardiovascular disease and diabetes. Screening early, and this includes children if there's a strong family history. Waist circumference and blood pressure measurements. And then certain labs we can do, fasting lipid profile and fasting glucose, that will let us know exactly if they have any glucose intolerance. Through the fasting lipid profile, that's where we get our HDL levels, LDL levels, and triglycerides. Other labs, high sensitivity C-reactive protein, fibrinogen, uric acid, and urinary microalbumin. Liver function tests, if you're looking for non-alcoholic fatty liver disease. Sleep study for obstructive sleep apnea. Testosterone levels, follicle stimulating hormone levels, luteinizing hormone levels, and these usually are needed for the diagnosis of polycystic ovarian syndrome. Now, treatment. There are many forms of treatment, so we'll quickly go into those. So lifestyle modifications, first and foremost being weight reduction. So obviously restricting your calories, increasing physical activities, and behavior modification, and that's where our CBT comes in handy. Diet. So approximately 500 kilocalorie restriction daily is equal to weight reduction of 1 pound per week, and that's considered the healthy level at which somebody should be losing weight. Diets restricted in carbohydrates typically provide a rapid initial weight loss. Adherence to the diet is more important than which diet is chosen. And recent studies do end up showing that, there are many diets. There's the beach diet, there's the keto diet, there's the Atkins diet, but the Mediterranean diet seems to be on, everybody's top list, that it's linked with, lesser chance of mortality and morbidity, and less likely to result in heart disease. A high quality diet, for example, enriched in fruits, vegetables, whole grains, lean poultry, and fish, should be encouraged to provide the maximum overall health benefit. Physical activity, they do recommend 60 to 90 minutes of daily activity, but as a standard, and this is what I advise patients also, at least 30 minutes per day for about 5 days out of the week, so 150 minutes per week. Gradual increases in physical activity should be encouraged to enhance adherence and to avoid injury. Those who are at higher risk should, get a stress test or EKG to make sure that they're okay to undergo such exercise programs. And physical activity could be formal exercise such as jogging, swimming, or tennis, or any routine activity such as gardening, walking, and house cleaning. I mean, they may not burn calories at a faster or at such a fast rate, but at least they're burning calories. So when all else fails, there are medications like weight loss medications, appetite suppressants such as phentermine and sibutramine. Orlistat helps absorb, they're absorption inhibitors, so in that sense it helps prevent weight gain. And then bariatric surgery is also an option for those with a BMI greater than 40 kilograms per meter squared, or slightly lesser, 35 kilograms per meter squared if they have comorbidities. Some forms of bariatric surgery have I have patients who've undergone bariatric surgery and now they don't have diabetes, or their glucose levels are well controlled, they're not on medications, so at least that risk factor has been eliminated. Hypertriglyceridemia, so a fasting level of 150 milligrams per deciliter, less than 150 milligrams per deciliter is recommended. A weight reduction of greater than 10% is necessary to lower fasting triglycerides. If your lipid panel is all good, but triglycerides are the only thing that's high, something like a fibrate such as gemfibrozil or fenofibrate, it's the drug of choice to lower them. And these help achieve a 35 to 50% reduction. Other drugs that lower triglycerides include statins, nicotinic acid, and high doses of omega-3 fatty acids. Another side note about triglycerides, obviously we have to keep them under 150, but the magic number also is 500, because if they reach close to or above 500, that's also linked with an increased risk of pancreatitis. So that's another thing to be watchful for. Let's say if there's a patient that's been seen in the ER multiple times for abdominal pain or chronic pancreatitis, and they're not alcoholic. The second thing that the first thing I think of if they're not alcoholic is, do they have untreated hypertriglycerides? So ways to raise your HDL, which is the good cholesterol. Weight reduction is an important strategy. There's nicotinic acid, and it's the only currently available drug with predictable HDL raising properties. And of course, the statins, fibrates, and bile acid sequestrants, and these will provide modest effects. And there is no effect on HDL cholesterol with ezetimibe or omega-3 fatty acids. Ezetimibe, that's generic for Zetia. Zetia used to be more popular, but I would say about 5 to 10 years ago, usually given with a statin to help boost the effect of the statin. So target level of LDL cholesterol, and remember this is our bad cholesterol. So for patients with metabolic syndrome and diabetes, LDL should be reduced to less than 100 milligrams per deciliter. But this is becoming the standard, to keep it under 100. Blood pressure control. There is a well-established direct relationship between blood pressure and all-cause mortality rate. Best choice for the first antihypertensive should usually be an ACE inhibitor or angiotensin-converting enzyme, or if they're not able to tolerate ACE inhibitors, an ARB, or an angiotensin 2 receptor blocker. So, for example, lisinopril, that's your ACE inhibitor. If they don't tolerate that, you can change to losartan or valsartan, which is the ARB. We have diuretics, such as hydrochlorothiazide, that's very commonly prescribed, or calcium channel blockers, such as amlodipine or diltiazem. In all patients with hypertension, a sodium-restricted diet enriched in fruits and vegetables and low-fat dairy products should be advised. Insulin resistance, it is the primary pathophysiologic mechanism for metabolic syndrome. We have several drug classes, biguanides, thiazolidine diones, such as TZDs, and these help increase insulin sensitivity. Both metformin and the TZDs enhance insulin action in the liver and suppress endogenous glucose production. TZDs, but not metformin, also improve insulin-mediated glucose uptake in muscle and adipose or fat tissue. Benefits of both drugs have been seen in patients with non-alcoholic fatty liver disease and polycystic ovarian syndrome, and the drugs have been shown to reduce the markers of inflammation and small, dense LDL levels. Continuing on with glycemic control, in patients with metabolic syndrome and type 2 diabetes, aggressive glycemic control will help lower cardiovascular risk. In patients with impaired fasting glucose without a diagnosis of diabetes, a lifestyle intervention has been shown to reduce the incidence of type 2 diabetes. And this is where metformin, which is still the drug of choice, has been shown to reduce the incidence of diabetes, although the effect was less than that seen with lifestyle lifestyle intervention. I know some ERs, even if you are still in the pre-diabetic range, they will send patients home with a starting dose of metformin and then have them follow up with their PCP. I typically still, if the A1C is 6.5 or higher, that is diagnostic of diabetes. So that's typically when I do start metformin, whereas 5.7 all the way up to 6.4 is pre-diabetes, which pretty much means get your act together, otherwise we can easily progress to diabetes, and then we'll have to be on medication. And of course, we cannot forget cognitive behavioral therapy. Thoughts create feelings, feelings create behavior, behavior reinforces thoughts, and cycles around to thoughts creating feelings. So, conclusions. Metabolic syndrome and diabetes are associated with increased levels of atherosclerosis and cardiovascular disease event risk, and lifestyle measures focusing on weight reduction, dietary and physical activity guidance are crucial in initial management. Clinical management should emphasize achievement of blood pressure control, cholesterol levels, glycemic control, and antiplatelet therapy. And then there are multidisciplinary programs, including primary care physicians, specialists such as endocrinologists and cardiologists, nutritionists and dietitians, and exercise specialists, which can be consulted for helping manage these conditions. And as a quick summary, just ABC for providers. For the A, make sure you're meeting the A1C target. Daily aspirin helps reduce the risk also. B, blood pressure control. C, cholesterol management. If they're smokers, cigarette smoking cessation. D, diabetes and pre-diabetes management. E for exercise and making the right food choices, which stands for the F. And that's about it.
Thank you so much, Vakil. That was a very thorough presentation.